Well, again, thank you to the Municipality of Kincardine for inviting us to come this evening and talk about the Local Health Integration Network. Normally, I go through my part of the presentation rather quickly, and I'm not going to make tonight a huge exception to that. But I do want to slow it down a bit because what I've been finding in these presentations we've been making over the last 2 or 3 months is no one knows who we are. No one really knows what we do. In fact, there was a young lady cleaning the floor out here when I came in, and she said, "Oh, you here for a presentation?" And I said, "Yes, we're a delegation." She said, "Where are you from?" I said, "The Local Health Integration Network." And she thought it meant Immigration Network. And I thought, this is not uncommon. Is no one really knows what the Local Health Integration Network does and who we are. And I hope you'll ask some questions pursuant to that before the evening's done. We have a lot of information to supply to you because it's a good news story. It's just a big moment. Look at that. So what is a LHIN? I'll refer to it as LHIN from this point forward. We're not-for-profit Crown art agencies that are responsible for planning, integrating, and funding local health services in 14 different geographic areas of the province. That's my hand in. I spoke too soon. What's in, what's out as far as a LHIN goes? We fund hospitals, psychiatric hospitals, community care access centers, community support and service agencies, mental health and addiction, community health centers, and long-term care homes. Excuse me, what we do not fund are physicians and clinics, ambulance service, and we get a lot of questions on that, laboratories, provincial drug programs, or public health. And Michael has some figures to go over with you in his part of the presentation. There are 14 LHINs across Ontario. This map gives a depiction of where 14 are. I'll go right to the next one, which is the Southwest LHIN. As I say, 14 areas across Ontario. Some are huge geographically and very sparse in population. As you can see, the Southwest is one of the largest LHINs, approximately 22,000 square kilometers. As a friend of mine said one time, you can probably read that for yourself faster than I can read it to you. But you can see for yourself it does comprise right from the tip of the peninsula down to Lake Erie and Lake Huron. It is a vast region. Some include some complete counties and some partial counties, and that may signify some questions that you might have later as well. I will draw your attention to the large proportion of seniors, and nowhere is that more evident than in the northern part of the LHIN. That includes Grey, Bruce, and municipalities such as obviously Kincardine, Tiverton, Port Elgin, etc. We'll also have a very small proportion of immigrants, but that is a growing population. We have a French language service designation that we share with the Erie St. Clair LHIN, which is the extreme southwest part of the province, down toward Windsor, Sarnia, Chatham, if you will. And that's a program that we've just entered into recently with the French language services to determine how best to provide service in the other official language to the citizens in southwestern Ontario. There are 5 First Nations reserves, and the large proportion of seniors is, as I say, growing significantly in this area. And across Ontario, I think it's probably the most significant area where we're having seniors growth and the issues that come with seniors growth as it applies to healthcare. More specifically, we have 19 public hospitals, over 32 sites. There is 1 private hospital in Woodstock. We have 1 single community care access center that covers the entire LHIN. 62 community support, 28 mental health agencies, 9 addiction agencies, 5 community health centers, and 76 long-term care homes, and 1 under development. From a governance perspective, and that's my main claim to fame, we are governed by a 9-member board of directors. Each LHIN has a board of directors that oversees what goes on. If you think of it as a hotel, we ensure that the hotel has a sufficient number of towels. We ensure that they have the beds and the cleaning staff, et cetera, et cetera. Mike's the operations, and he's the CEO. He'll talk more about what that role entails, but that's where the rubber hits the road, where the actual work takes place. I'm the chair in London. We have Ron Bolton with us from St. Mary's, retired from the bank. Cheryl Fagan, a lawyer from Goderich. Ron Lipset, from up in Anway. Janet McEwen, who should be leaving the board within the next few weeks. Janet's done her 6-year term on the board. I've known Janet for a long period of time from the St. Joseph's board before, very active in the City of London, and a huge proponent for mental health. She's going to leave a huge hole. Jerry Moss, who was with us this evening, has just joined our board from Port Elgin, and is bringing another voice from this part of the world down to the LHIN meetings in London, and where we're taking throughout southwestern Ontario. Linda Stevenson is our vice chair from St. Thomas, and Barbara West Bartley from Wyerton. So there's a great amount of representation coming from this part of from the LHIN. We do have one vacancy. I suspect that vacancy will be maintained. I don't believe we're going to be filling that vacancy. We did put a request in some time ago to the minister's office. We haven't heard anything, and given the state of finances right now, I would be surprised if that position is filled, which is fine. We can carry on very well with an 8-person board. We haven't had a tie yet, so it hasn't come down to an issue any type of votes. I'm pleased to say that LHINs are a made-in-Ontario approach. And that's to say that it was created in response to the challenges and limitations faced by the health authorities across Canada. In a lot of other jurisdictions around in the country, the local boards were eliminated when LHIN-type organizations were put into place to handle health care. When George Smithon was the Minister of Health here in Ontario, he had the foresight to maintain local boards, and I applaud that. I think local boards are important. We get a lot of representation from local boards. We have board-to-board meetings that are attached to our own board meetings where we interface with, might be usually health service provider boards, but it could be a board from any jurisdiction to talk on governance. And it provides a voice to ensure that we're as transparent as possible, getting the message to as many people as possible, understanding we're never going to be all things to all people. It just doesn't work. We do seek to work collaboratively with health service providers and the governing boards. We do not supplant them. That's not the name of the game. We do push for every opportunity for integration and where we can make the system work best for all of our citizens and clients in southwestern Ontario. We do endeavor to engage communities in meetings such as this. The legislation demands open, transparent, and local decision-making, open board meetings, and community engagement. And I hadn't done a lot of that before I joined the LHIN board. My experience was our meetings were somewhat transparent, but not totally open to anybody who wanted to walk in. And I've got to tell you, I find it refreshing. Quite frankly, I'm sitting on the LHIN board, and any one of you or anybody out in town here could actually sit on the LHIN board. So there's no secrets going on. I would have to think that we're talking about healthcare is important to the citizens, and there's no reason why they shouldn't know what is going on. We do go into closed session from time to time. We're talking about Mike's salary, or if we're talking about some other issue, but other than that, it's an open forum for anyone who wants to attend, and we get sporadic attendance at these deals. We just had a board-to-board and open session in London that was particularly tuned towards mental health, and I think we had 70, 80, 100 people that attended that from the public. It was overwhelming, as well as probably 30 fellow board members from other boards throughout, largely the London area, attended that session as well. So it was a well-attended session. The 14 LHINs do take on all responsibilities that were previously handled by 23 offices across Ontario, that being the 7 regional offices and the 16 district health councils. And I think Mike will probably get into this as well, but before I hand my piece over to him, we know we're getting a lot of press from politicians that don't think the LHINs pay their way. And Mike will have some numbers to, I think, clarify some of those issues. I've got to say that I've become quite a believer in the LHINs exercise. I've been involved in healthcare for darn near 19 years in one capacity or another, mostly out of London. And I've got to say that the transparency, the authority, the delegation of authorities is nice to have. We're not as beholden to the Toronto, if you will, as you might think. And the fact of the matter is that I think if the LHINs do not exist down the road, we won't be having meetings like this. I can virtually guarantee that. And there's going to be a lot of persons wondering what happened to the transparency and what happened to the communications flow. You never get everything you want. That happens in my house too. But the bottom line is that this is a lot better than what we had. And I was talking to Dr. Wilbert Keon, the heart surgeon, is also the senator, and now he's the board chair in Ottawa. And he's on record as saying the elimination of the LHINs would be the stupidest thing that any government could do down the road. And frankly, I agree. You don't have to, But I agree. I think I think it would be a travesty if we started to try and move back the clock. You can't rewrite history. It's taken 5 or 6 years to start to get things more and more right all the time. And I think we're getting more and more things right all the time. We're having more and more people come and talk with us. We're getting out and talking to more and more people, and which I enjoy, because as I say to a lot of people, I live here too. It's important to me that we have good health care. It's important to me that we have retirement homes, etc. I'm heading that direction myself. So it's not as though I'm visiting from another planet and I'll be leaving right after this presentation. This is home for me too, and so it's important. And I hope you'll ask questions when we're done. I think you'll find, and I'll comment on it if it's appropriate, but I think you'll find that a lot of the questions you may have are the same questions this board asks within the LHIN and within the ministry as well, because we all have a vested interest in the deal. And with that, Mr. CEO, I've taken up all your time, and I'll turn it over to you.
Okay. Thank you, Jeff, and thank you, Mayor and Council, for having us here today. Certainly nice to see a lot of familiar faces. I was trying to count the number of times we've been in Kincardine since the creation of LHINs back in 2006, and it's been a number. We actually had a council meeting here back in 2008, had lots of community engagement sessions, including right here in this council chambers, some very controversial discussions. The community center, we had a large delegation back 3 years ago, so we've had hopefully a good presence within the municipality of Kincardine. You'll see that we're videotaping today, and as Jeff alluded to, we often hear that, well, what are LHINs? Don't know what this LHIN thing stands for. We now videotape everything, and we put it onto our website, and we use the YouTube video site for doing that. Our YouTube video site now was in first place of all not-for-profit YouTube sites across Canada the last 2 weeks, simply because we're recording not just Jeff and I, but also our providers are doing presentations. So it's a cheap, easy way to get our message out, because we don't have a large communications budget, so it's a way that we get to communicate to the public. So again, thanks for having us here. And Jeff and I are happy to answer questions at the end, or if you want to stop me in the middle of the presentation, I'm certainly happy to do that as well. These next 4 slides are showing where the money is spent within the healthcare system. The first 2 are the overall government picture in terms of expenditures, and we break it down into the Ministry of Health and then break it down into the Southwest LHIN. So this first slide shows where the Government of Ontario spends its allocation, the $115 billion that's make up the provincial budget. You can see that health consumes the lion's share of spending, $46.1 billion, that 40%, which is the blue piece on the right-hand side. Other significant components, as you can certainly know, I'm sure, education with $21 billion, post-secondary and training at $8.1 billion. But health, again, is the lion's share of the provincial expenditures at $46.1 billion, 40%. This next slide is the exact same slide, but it includes interest on debt. So you can see the total at the bottom has risen from $115 billion to $125 billion. Every year, the province of Ontario spends $10 billion on debt. And putting that debt repayment into the calculation, you can see that the amount spent on health is actually reduced to 37%. The raw number is still at the $46.1 billion, but the percentage drops down to 37%. And the reason we include that in there is because there's a conversation that have been having for the past number of years, and it's going to become much more serious. That interest on debt is going to grow to $12 billion within the next couple of years, and that means health continues to see increases. So this year in the provincial budget, there's an increase to health and to education, but those increases are at the expense of the other components of the provincial budget. So as health and education continue to grow in terms of funding allocations, it's at the expense of other services that the provincial government delivers. So we need to look seriously at how do we sustain the healthcare system. We can't continue to spend at the same rate that's been being spent in the last number of years. Now that I keep going the wrong way. The $46.1 billion is now broken down into this next slide. So the amount that's spent by the Ministry of Health within the provincial government, this is how the Ministry of Health spends its money. You can see that, again, the largest component goes to LHINs, the 14 LHINs that Jeff described. We received $21.5 billion of the Ministry of Health budget. That's about 48%, the large green piece on the left-hand side. The other significant portion here is OHIP. So the blue piece on the right-hand side, $16 billion, or 37% of the Ministry of Health budget goes to OHIP. So those are physician payments. So that's a significant component of the Ministry of Health budget. A considerable amount goes to hospitals and long-term care homes and community care access center, but an equally significant amount goes to physician payment and other payments associated with OHIP. In this final slide is how much we spend within the Southwest LHIN and where it goes. So our organization has an allocation of $2.04 billion. 72% of that money goes to our 19 hospitals that we have across the Southwest LHIN. So that includes South Bruce Grey Health Center, Hanover District Hospital, Grey Bruce Health Services. All those organizations make up that $1.48 billion that we allocate for hospitals. Another significant component is long-term care homes, where we allocate over $276 million to long-term care. Our CCAC, our Community Care Access Center, is about $168 million. I'm just going to go back, and one thing that I wanted to show you as well. This is the Ministry of Health budget again. You can see the amount spent on hospitals and long-term care through LHINs, the amount spent on physicians through OHIP. Look at public health in the bottom right-hand corner, the red slice, 2%. So we spend a significant amount on taking care of people once they're sick and once they need care, but relatively speaking, very little on the prevention and upfront promotion that we need within the healthcare system. So in terms of accountability, the Ministry of Health provides our LHIN with over $2 billion. In turn, we sign an accountability agreement with the Ministry of Health. So Jeff signs the agreement, our board chair, with the Ministry of Health, and it says for that $2 billion, the LHIN needs to deliver on a number of different indicators. Most of ours are related to wait times around surgery, around MRI, around CT. So that accountability agreement is in place. In turn, for all the 150 providers that we fund, so South Bruce Grey Health Center or Meals on Wheels or VON, any of the organizations we fund, we have an accountability agreement with them. And just like our agreement with the ministry, we outline what we want for the money that we're providing to those organizations in terms of wait times, volumes of service. That ensures that they're actually performing the way they should be performing. And if they don't meet those targets, don't meet those indicators, we go through a performance improvement process where we have a first an initial meeting to talk to them about it. And if things don't improve, then we take more significant steps. And a good example, when LHINs first started back in 2006, we had 3 hospital organizations that had significant financial issues. Grey Bruce Health Services was one of them. And in those 3 hospitals, we actually appointed an external reviewer to come in and look at the finances of those organizations. And I'm pleased to say that those 3 organizations are all in a balanced position now, including Grey Bruce Health Services. So if performance is not up to what's been required in the accountability agreement, we now have mechanisms to ensure that we get them back on track. So for the first time in Ontario, since LHINs have come into place, we're now measuring healthcare performance. We're setting targets based on measures. These things did not exist prior to the introduction of LHINs. As I indicated, we're holding organizations accountable for achieving these targets and publicly reporting our performance results. So if you look on our website, you can look at our performance for all of our indicators around wait times, any of the other measures that we use with our organizations to ensure that the public knows what's going on. And the bottom line here is that achieving those targets helps improve the lives of the patients, clients, and residents that we have responsibility for. So Jeff referred to if you listen to the media, there's no shortage of criticism of the LHIN environment. I think there's a number of reasons why LHINs are beneficial to the system. Obviously, I'm a bit biased sitting in the chair that I sit in, but we've been promoting this message. Within the Southwest LHIN, we allocate over the $2.04 billion to the 150 health service providers. Our budget is $5 million. So that means that 99.75% of all of our funding is going to our health service providers. We spend 0.25% of our allocation on the administration of our budget. LHINs also provide the opportunity to look at things from a system perspective, and this has become so very clear. I started my health career working for the Ministry of Health, so I've worked in the system for a number of years, worked at London Health Sciences Center, the Children's Hospital, and I know that organizations in the past have a focus primarily on their own organization. So what's good for their organization is what they focus on. There's now an obligation within under the legislation that created us, the Local Health System Integration Act, to have responsibilities for your neighbors. So what this means is if a hospital has a program that they're saying, well, we're not going to provide that program anymore, we're going to cut it. There'll be a benefit financially to that organization. They now have an obligation to talk to their neighbors what the impact will be for any change to that service. Before there was, if I can say, lip service to that responsibility. It's now in legislation where they're required to do that. So as it says in the slide, LHINs have or health service providers not only have to do what's right for their own organization, but they have to do what's right for the entire healthcare system. So how do LHINs and municipalities work together? I've told this story at other municipal presentations that I've done. I actually started my career as a land use planner, so I was for 10 years worked in different municipalities around southern Ontario as the town planner in Tillsonburg and Ingersoll, places like that. I also set up the 911 system in Oxford County, so I work closely with the emergency response officials, but also closely with the hospital system. And I can tell you, back in when I started, that's going back probably 20 years ago now, the connection between municipalities and their healthcare organizations probably wasn't that strong. We all went about our respective business. But in today's environment, decisions that our board is making around the healthcare system have an impact on you as municipal councilors. If there's any changes that our board is making to health service providers, whether it's in a hospital or whether it's in a community provider, and the public is concerned about it, it's counselors like yourselves that are going to hear about this in the grocery store, at the arena, at the library. So we need to ensure that our decision-making process involves municipalities and that we're respectful of the roles that municipalities play within the system. So our intent today is to ensure that we've got open dialogue with you and that you have an opportunity to ask us about any questions, any concerns that may be coming up. And I know probably some of the questions that will be coming up later from some of the council. Our intent is to have a more open, transparent relationship between municipalities and ourselves. So we've been doing these presentations to a number of municipalities across our LHIN to ensure that happens. The last point on this slide talks about LHIN boundaries. And it's not such a significant issue here in Kincardine, where you know other LHIN to go to because you've got the lake to the west and the peninsula to the north. But in those areas where the LHIN boundary, a municipality is close to a LHIN boundaries should not affect patient, client, or resident flow. And if you ever hear of someone saying that, well, you know, you're from the LHIN in the Erie St. Clair LHIN in Sarnia, we can't service you here in the Southwest LHIN. That's contrary to legislation and contrary to the spirit and intent of the creation of LHIN. So if you do hear that, please let us know. And as I said, it's probably not such a big issue here, but in other municipalities, it is a significant issue. So some examples of value, and Mayor Kramer heard these examples when we presented to Bruce County Council 2 weeks ago. But I'll just talk about a couple of them. And how much time do we have? I don't want to abuse our... Somebody said I'm done.
That's the press.
They want to go home.
You have a sign you need.
Okay, I'll go quickly through these. Obviously, I'm not entertaining the press here. MRI. This is a great example of how looking at things from a system perspective are beneficial to the system, beneficial to the patient. 3 years ago, we have 5 MRIs across the Southwest LHIN, 4 in London, 2 at each of St. Joe's and LHSC, London Health Sciences Center, and then 1 at the Owen Sound site at Grey Bruce Health Services. Back 3 years ago, the wait times for MRIs in the London hospitals were over 220 days. So if someone wanted an MRI, non-emergency MRI, that would be over 220 days. In Owen Sound, the wait time was 28 days. So Owen Sound had the lowest wait time for MRIs across the entire province. And we said, that's not a great use of resources if you've got such a short wait time there and a longer wait time in London. So we established an MRI, a capacity review group, which was composed of reps from both hospitals. They did their own work internally to ensure they had good flow of their patients through the MRI system within their own organizations. But what we did as a LHIN, we sent a letter out to all family physicians across the Southwest LHIN and said that if your patient needs an MRI and you're sitting here in Perth or the southern part of Grey County, don't send them to London, send them to Owen Sound. And I think there's a perception that if you go to the teaching hospital, you're going to get better care. An MRI is an MRI. And the MRI, once it's taken, all the hospitals have a picture archiving system where they can look at those MRIs at any hospital across the system. So what has happened now is that our MRI wait times have dropped at the London hospitals. They've increased slightly at the Grey Bruce Health Services, the Owen Sound site. I think it's now about 36 days that they're sitting at. But making more effective the effective use of the resources that we have across the system. There's a new MRI coming into Stratford Hospital, which will be operational. I don't know exactly when it's sometime this fiscal year. So that's additional capacity that will be coming in. So people that are east of here can certainly access the MRI in Stratford as well. So before, organizations would have worked separately and distinct from themselves or for themselves. Owen Sound would have had this great MRI wait time, but having the system function across a larger geography allowed us to drive the wait times down across all sites and provide better service for our patients. There's a slide at the end of the presentation that shows our wait times for CT, for knee replacement, hip replacement, cataract surgeries. All those have dropped significantly since the introduction of LHINs. We've had a real focus on ensuring that those wait times have dropped. The third one, life or limb. In the past, with hospitals operating as distinct standalone organizations, you could have a family physician calling from Listowel saying, I need to get that patient into London, it's life or limb, and the London hospital could have said, well, we don't have any beds. We don't have any beds, so that patient is going to have to go elsewhere. So that physician is back on the phone calling someone else to try and find another location where that patient could go. This has gone on. It still goes on in other locations across the province. In the Southwest LHIN, we have a critical care lead, so he's an ICU physician from University Hospital in London, and he now has the critical care units for all of our hospitals working together within a system. And with his name is Dr. Mike Sharp. With Dr. Sharp's leadership, we now have a life or limb policy where if anyone's calling a hospital and it's life or limb, the hospital has to accept that patient. It seems crazy that you can actually have hospitals refusing a patient when life or limb is at risk, but that's what we were faced with in the past. We now don't have that. Any person that has a life or limb issue will be taken care of within the hospital that's called for, and there's a protocol to ensure that it's not abused as well. The last example is the Southwest Physician's Office Interface to Regional Electronic Medical Record System. SPIRE is the acronym. You're probably familiar with this if you've been in your family physician office having tests. Right now we have hospitals that are doing tests, whether it's diagnostic imaging tests, lab results, and they're being faxed to the family physician office. I'm not sure who uses faxes anymore, but one of the few places in the world that still do, or still in Canada, is within the healthcare industry. It's absolutely ridiculous. We shouldn't be using faxes when we have the capability to send things electronically. So we've instituted the SPIRE project. We now have 350 physicians, family physicians hooked up, where they can receive these lab results, diagnostic imaging tests electronically from hospitals directly into the family physician electronic medical record. So it's downloaded right into their medical record. It goes into your medical record, and it's there for the physician to view. This is the way the entire system should be working, and we intend to have that number up closer to 600 family physicians by the end of this fiscal year. Some of our priority projects that we're focusing on, and I'll go quickly through this list, but the one that I want to just speak to briefly is Home First. We have a philosophy in the healthcare industry where If you have a frail senior who presents within hospital, as soon as they get admitted to the hospital, the conversation is about, well, we need to get them into long-term care. The conversation shouldn't be about getting them into long-term care. It should be about getting them into back to their own home. And if they need supports from the CCAC or from a community provider, that's the conversation we need to be having. And we're embarking on this home first philosophy together with our other 13 LHINs to ensure that becomes the philosophy across the entire system. We're also auditing all of our 154 hospitals across the province to see how senior friendly they are. The majority of the hospital's business is with seniors, so we need to ensure that if there's improvements that need to be made, those improvements are actually put into place. Lots of other work that we're doing here. The falls prevention strategy, which the Grey Bruce Public Health Unit, I don't have the title right there, is working closely with our hospitals to reducing the rate of falls by seniors. Lots of challenges within the healthcare system. Staffing challenges. You may have heard that we're having difficulty staffing the urgent care center at St. Joseph's Healthcare in London. It's a conversation that this community is familiar with and other communities are familiar with, trying to staff their emergency departments during the summer months. So lots of challenges. Our wait times for cancer surgery within the Southwest LHIN are the worst in the province. And so we have a concerted effort right now to ensure that our cancer surgery wait times go down. Mental health divestment, we're moving beds from the old London Psychiatric Hospital, St. Thomas Psychiatric Hospital to Windsor, Hamilton, and Kitchener-Waterloo. Lots of focus on alternate level of care. These are patients that no longer require hospital care. So there's lots of challenges within the system, and increasing costs are always an issue within the healthcare system. But as I said at the start, we're one of the few sectors that are still seeing increases on the revenue side. These are some of the successes that we've had around our wait times, which I mentioned earlier around with MRIs and CTs and others, which are there for your review. And Jeff and I are happy to answer any questions that you may have.
Okay, does anyone have any questions for Mike or Jeff? Ann,
I have a few questions, but first of all, I would like to thank you for coming today. I did enjoy my trek down to Zurich to your meeting down there and the opportunity to talk to you. I really like your policy of the opportunities for input. I really appreciate that. So I have two areas for questions. The one concerns our local hospital. And last year, I went to the workshop that they had regarding the plans for the new hospital, and I reviewed them. I think it's a very good plan, very encouraging to us, and with the different areas analyzed and future needs incorporated. So our big interest is, do you know what the status of these Kincardine hospital plans are right now at the Ministry of Health? Are they on the 10-year capital plan? Can you give us any idea of that? That's my first question.
Sure. I should start by saying that approvals for capital projects rest with the Ministry of Health and Long-Term Care, so the LHINs don't have the approval authority for capital projects, although we review all capital projects to ensure they're in alignment with the system needs across the geography. The Kincardine proposal has gone through a very rigorous process of community engagement with stakeholders across the geography. The ministry has indicated that you now have approval in principle for stage 1. The capital approval process is a 5-stage process. So the next step in this process is actually to get approval from the government to be on the 10-year infrastructure improvement list, which that list has not come out yet, so we don't have any insight that we could provide today to council to say that you're going to be moving forward. So the next step is to wait for that indication from the government to say that you're on the list. I'll just make sure council is clear that, as you can imagine, there are many other capital projects across the province that are looking to get on the list as well. And they're all anxious, and it's probably the question that I get asked the most when I'm out and about is, do you know about our capital project? we need to wait and see when that list is actually released, and you'll have a better indication of how you're going to progress going forward.
Thank you. The other one, the current buzzword I've been hearing lately at meetings I've attended is centers of excellence. And do you know if any centers of excellence are being planned for Kincardine, like cardiac or mental health and addictions, or that? Do they have the different categories?
No, I think as we go forward within the healthcare system, we need to look at every hospital has kind of been a catch-all for everything. And we need to evolve beyond that to look at where do we focus particular services and create centers of excellence so that they can be successful at a smaller number of priorities. I have not had any conversation with anyone within the Kincardine area or with South Bruce Bay Health Center about designating Kincardine as a center of excellence for any particular program. But it's certainly something that I certainly wouldn't discourage, because I think that's where we're headed. You can't have every hospital doing everything. You need to try and focus on what you're good at.
Thank you. I had one more question related to home care, but I just thought when we're talking about hospitals, maybe I'd let some of the other counselors or people in the chamber talk about that first, but I would really like to address home care later.
Maureen?
But perhaps a strange question, but if a physician orders an MRI, does the LHIN then decide whether that person's qualified to get one?
No, it wouldn't be the LHIN, because we don't have any responsibilities for patients. But your question is very good, because right now the volume of MRIs that are being requested is growing considerably. And we need to set criteria around when does a person actually need an MRI. And you look at some of the yields of MRI tests that are provided, and I don't want to give data that I don't have here in front of me, but an MRI for a headache very seldom yields something of significance from the test. So do we do other tests in advance of doing the MRI to say, let's make sure that we've done all our due diligence before we order this very expensive test? Right now, MRIs have become, for those residents that are going through a training in a teaching hospital, MRIs are just part of regular business. Here in a rural community, it's much more, you don't have that easy access to MRIs. So we need to create criteria to ensure that we know when a person should actually be going for an MRI and not ordering them unnecessarily.
So since you're in the process, it obviously shouldn't be happening now, but it is. Do you know who's refusing?
Who's refusing MRIs? So again, it wouldn't be, I wouldn't have that knowledge in terms of individual patient information, but it would be a decision that would be made by the physician and then the receiving hospital that has the MRI facilities.
So it's up to the local board of the hospital then?
I wouldn't say, yeah, it's a clinical decision, so it wouldn't be into the governance level of the board. It would be a clinical decision at the physician level.
My second question is, we received from our association, our municipal association today, a little brief on the proposed Conservative Party platform should they be elected in October. And one of them was get rid of the LHINs. And AMO made the comment that they don't know what they're going to replace them with. So they weren't able to comment. I'm just wondering if anybody's been questioning the LHINs or surveying the LHINs or finding out if there's any inkling of what might. And I know I'm asking this in a void because we of course don't know what's going to happen. But is there any preparation being done that you know of if you're axed all of a sudden? Or I'm just have a very big concern about a whole.
So again, I'm coming from a biased position, so I said that most of the question I received most is around capital. That's a lie. The question I received most is what's going to happen on October the 6th about LHINs. That's what I can ask the most. Mr. Mayor, I'll tell a little story that will help describe how we're going about doing this. The London Chamber of Commerce came out with a pre-budget consultation report, which outlined what they wanted to see within the last provincial budget in March. They had policies around transportation and economics, and under the health recommendations, they had two. One was to hold the line on spending, and the other was to get rid of LHINs. This made the Minister of Health, who comes from London, very upset. And so we scheduled a meeting with Minister Deb Matthews and the CEO and the board chair of the London Chamber of Commerce to say, why did you put this in there? They started their presentation by saying, we didn't have any basis for making the recommendation. We just saw you as an unnecessary layer of bureaucracy. I'm sure you're here today to tell us how great you are, so go ahead and prove it. And he pointed at Jeff and I just like that. Go ahead and prove it. So we had a presentation put together, and we talked to him about accountability agreements. We talked about public board meetings, transparency. As a guy who worked within the Ministry of Health, I know that in the past, hospitals would have private hallway conversations with a senior level bureaucrat to say, I need that $2.1 million to balance at the end of the year, or we're going to have to lay off nurses. And that's exactly how the system worked, private conversations. That would never happen. All of our decisions are now made in public open board meetings. And it's local decision making. And so we said this back to the London Chamber of Commerce, and all the things that you espouse as a chamber, less big government, local decision making, open, transparent decision making, more accountability. The amount of money we spend is very small compared to what was in place in the past. And he said, both of them, makes sense. The next Saturday in the newspaper, he wrote a commentary saying, LHINs have a strange name, but there's value. So that's our difficulty, is that I know what the system was like in the past. I know what a difference we're making now, and it's not perfect. But things are way better handled now than they were in the past with the regional offices and district health councils. It's just for us trying to get the message out there to tell people about it.
Jackie?
I have a few questions, just a few comments. I noticed that mental health receives such a small slice of the pie. I also heard you say that one of your mental health advocates would be leaving the board. Just want to make public the need and the hole that's going to leave such an important component of health is mental health. The other thing that I often hear and get comments about is that London, Ontario has become the new Toronto and Ottawa with regards to healthcare in the Southwest. In other words, with more and more centralization and the operation of LHINs, we're seeing less and less appreciation for rural reality and rural challenges. Perhaps an opportunity here just for you to comment on that and to ensure us that I'm sometimes worried about this notion of centers of excellence and centralization of healthcare, given that we aren't like London, we aren't like Toronto or Ottawa. We do face very unique and specific challenges in rural communities. How can you respond to that as a LHIN?
I'll answer the second question first around the centralization of services. I indicated that our cancer surgery wait times are the worst across the province in our LHIN. 76% of our cancer surgery is done at the London hospitals, and the London hospitals have a significant patient flow and access issue right now, which means that they're having trouble getting patients in because they don't have enough beds available to offer that service. So our philosophy at the LHIN and with our 19 hospitals is exactly the opposite of what you described. It's actually to get services out of the City of London hospitals and into some of the rural communities or community hospitals. Places like St. Thomas, Stratford, Owen Sound, Walkerton, even small places like Tillsonburg are doing cancer surgery. So we need to look at providing a regionalized system of cancer surgery so that we're actually getting those cases out of the City of London and reducing the amount of time that people have to travel into the city. There's this perception, and there's lots of different reasons for it, but a perception that you get better care within the London hospitals is not the case. If you're part of a regionalized system, you can do great things in terms of having more services provided in community hospitals. The mental health piece, no question, in the last 3 years, for the last 10 years, hospitals have received the largest increases within the healthcare system. That's the exact opposite in the last 3 years. Hospitals this year are getting a 1.5% increase, whereas mental health and addictions agencies are getting a 3% increase. And that was the same last year. Numbers are different, but then hospitals got less than the mental health and addictions providers. And finally, the mental health piece, with the movement of beds from the Regional Mental Health Care in London, the former London Psychiatric Hospital, to different communities, some of the patients are now, beds are being reduced, and we're moving those patients into the community. So we've lobbied to ensure. We just received an additional influx of $2.9 million to create community capacity, supportive housing, crisis services within this is predominantly in the City of London, but available for those patients that require care within the community. So it's a big focus for us, and the board keeps me focused on it as well, because we don't want to lose sight of it.
Okay, I just have a few other questions, and just to summarize that, you're asking for municipal feedback. I just really want to reiterate mental health realities in rural communities, and also the cautions that should be heeded when we're talking centralization. So those would be my concerns. Couple more questions. As you probably know or heard, the municipality and our community more generally has been dealing with the Green Energy Act and wind turbines. There is a good proportion of our community that is currently ill because of the impacts of industrial wind turbines. Does the LHINs have any resources, comments, statements with regards to helping these people in our community who often turn to medical practitioners and are told that they're crazy? What can you see in the future for that role, that particular role?
To be perfectly frank, I don't see a large role for the LHIN in that conversation. I see it's a conversation from the primary care level with the family physician, with public health. Both of those pieces of the healthcare system we don't have responsibility for, so I don't want to lead you astray that we'd be. It's not certainly not on our front burner, and I don't anticipate it being on our front burner in the near future.
Okay, thank you. And lastly, just wanted to ask you about your overall perception or feelings towards private service providers in the community. Because of our rural realities, I would anticipate in the next few years that some of the gaps and the holes that we have, in particular in long-term care and home care, are potentially going to be filled by young entrepreneurs coming into the community and saying, listen, I can do this privately. There is a fraction of our community here who has disposable income or who has an insurance policy that will provide for good home care, but through traditional routes can't find staff for that home care. What would be your working relationship with these private providers?
So the majority of the services that are provided by community agencies are contracted through the CCAC. Right. So the CCAC has a competitive process that they'll put an RFP out to say, we want to provide personal support workers or registered nurses or home supports. So any entrepreneur could be part of that process. And again, I don't want to get into speak on behalf of the CCAC because the RFP process right now has been put on hold, but the CCAC goes through a competitive process to identify private or not-for-profit providers that could provide those services. So the opportunity does exist. It just depends on when that contract would become available, when the RFP would become available.
Okay, thanks. And last question: how would you describe your relationship with working with hospitals in rural areas such as Bruce County?
Again, a bit biased, I'll say, but I think at the start when LHINs were first brought in, hospitals were quite concerned about the role that LHINs would play. They were used to dealing with these, as I said, the story about the hallway conversations within the Ministry of Health. I think it's taken them some time to learn that we are going to make every decision in public, which they weren't used to. But they're now very much used to that process. We meet with our hospital CEOs and the CCAC CEO every second month. So Maureen Selecki, Paul Davies, Katrina, meet with us on a regular basis. So I think our relationship is solid. When you're the funder and they're the provider, there's always a tension there of, negotiating an accountability agreement. Sometimes there's some bumps, but I think overall that our relationship is good.
Thank you.
Okay, I have Randy next, and then you'll have to show me your hands again if you want. You can.
And maybe, Mr. Mayor, sorry, I'll make one more comment in terms of a personal observation. My mother-in-law is from Teeswater, and so she's familiar with a lady who's gone through quite a bit of number of issues with mental health. And accessing services in Teeswater has been a tremendous challenge, so my mother-in-law keeps me on my toes with ensuring that.
Go ahead, Randy.
Yes, thank you for coming again. It's good to put faces on names, okay? So I'm going to have a few questions, and first of all, I'm going to ask the question, your territory for LHINs for this area is very large. And first of all, I would like to know who decided on these borders? What political genius person said these are the borders that you're going to stay within, and these are the services that you're going to require? So who made that decision?
So it was made by the Ministry of Health and Long-Term Care. It was based on an indicator called a localization index, which means how much of your population actually receives services from within this LHIN. Our localization index is one of the highest of the 14. It's about 97%. So 97% of our population actually receives services within the LHIN. They don't have to travel out to another hospital or another organization to get that service. So that's how those borders were made. The good thing of Bruce County is that your complete county is in here. When Jeff and I met with the municipal group in Flesherton, unfortunately, Grey County is cut in. Some of their municipalities are cut in half, and some go to other LHINs, so it's an issue for them.
And I think when Jacqueline touched on the rural, larger urban center aspect, I think the people in the province of Ontario, from rural Ontario, have always felt that they're the poor cousins to the larger urban areas, because they're the ones that got the walk-in clinics and got all the services, and we're the ones that had to travel for miles and miles to receive the same treatment. So that's why I'm saying why the large area for the Southwest LHINs. I feel that there's an ability to cut it up even more and have provide better coverage for all the people in it. I think it's too large myself. Okay. We also touched on the hospitals, and you mentioned that the ministry decides whether you're going to get a hospital or not. Okay. If you waited on them around here, and we've waited for over 30 years for the provincial governments, period, to make a decision. And you say that, you look over the plans, and I'm sure that you have input, or some sort of input, because the bottom line here is, if you're going to provide health services to an area, period, and you have a hospital that they're looking at upgrading or replacing completely, how are you ever going to decide what type of service that you're going to provide to the people that are going to be associated with this hospital? You have to have some input, or you need to have some knowledge of what you're going to provide. Do you know what you're going to provide for health coverage in the Kincardine Hospital today? Do you know that? Do you know what you're going to provide for the new hospital?
So it's a great question. I think what I said earlier about the healthcare system in the past being driven by individual organizations, especially in the capital process, if you had a hospital with a strong connection to the government, a strong lobbyist, you could actually move your proposal ahead faster than some of your colleague hospitals. Now with the LHIN, we need to look at things from a system perspective. So it's no longer an individual organization that's lobbying for this, for changes to their hospital or a capital project. The LHIN provides input to say, well, is the investment in Kincardine Hospital the right thing? Are the services that are being proposed in the Kincardine Hospital the right thing? Our board did that, or our staff did that analysis, provided it to our board. Our board passed a resolution back, and I don't have the dates here, it must have been last fall, endorsing the programs and services that Kincardine is putting forward. And this is part of the capital approval process. So our board has to review it. They've sent that off to the ministry, and that helped complete that stage one proposal, which you're now at within the capital process. So, yes, this is what capital redevelopment should look like. Same with Wingham. We needed to look at the programs and services that they're proposing in their capital projects. Same with St. Thomas. Same with the London hospitals. That's our job now to do that.
And I think when you say you want community input, I think the LHINs as well as the provincial government have to realize one thing. If you want community input into your projects, then we don't need political fertilizer. We need answers. When we ask the questions, the people ask questions, they want to hear the answers. And yes, maybe we're not very happy with some of the answers we get, but at least we need to know what's going on. We are, I'm hoping, part of the province of Ontario, and we need the health care just the same as somebody from London or Toronto. The other issue that I'd like to bring to your attention, and again, Jacqueline touched on it, there has been a move afoot with respect to the wind turbine issues in the province of Ontario to have a health study done to prove some of these facts. It has fallen on deaf ears. I don't know whether your organization works with people who have deaf ears. I hope they do, because you have a provincial government that's fallen on deaf ears. I'm wondering, do you have any input, or do you feel that you have an opportunity to put input to the Minister of Health with respect to getting a health study done for the province of Ontario?
And Mr. Mayor, through to Councillor's question, I think we need to stick to our knitting, and I think that goes, as I said to the other councillor, this goes well beyond our scope and responsibility within the healthcare system. There are organizations within the healthcare system that have this responsibility: public health, primary care. We have a responsibility with our health service organizations. So I don't want you to think that we're going to move forward and start a dialogue with this conversation. It's definitely outside of our scope.
And is that wrong?
I think my biggest concern with the providing of the health services as far as the LHINs are concerned is, again, on the migration of services away from this area. We've seen more and more and more things leave. I mean, you can't come to the Kincardine Hospital and start a family. You have to drive for hours to get out of the area. And, you know, when it comes to considering things, I mean, if you're having a health issue, if you're a cancer patient, how realistic is it that we have to get in the car unwell and drive 2 hours to an urban center to sit in a waiting room for heaven knows how long to receive a treatment and then get back in the car and do it again? I mean, if you're requiring a health service, you already are somewhat enabled to a certain degree. I mean, on a varying scale, of course. And you talked a lot about the fact that our population isn't aged group. So now we're putting an aged ailing group in the car and sending them to London in the middle of January when, making it across town may be challenging in itself. Do you have any type of conversation around feasibility about that? I mean, it's great that, you could go to London and see somebody in some time frame, albeit not necessarily reasonable, but that's really only half the problem. So do you have any input on how accessible are these services, even if they exist?
Right, so it's really at the root of health system planning. What services are required in Kincardine versus what services are required in Owen Sound versus what's required in London. And you start at the basic level, primary care. I think you want to ensure you've got a strong primary care system, which is family physicians within your community, and that's across the board. Then you move it up to secondary services, so those services that would be provided at Owen Sound or Stratford or Walkerton, Goddard in some cases. And then you look at those specialized services. From a health system planning perspective, it doesn't make a lot of sense to have those specialized services scattered across a community, because you never be able to support them from a physician perspective. You need to have a volume of patients that are available to go to that program. So I think communities try and focus on what's the basics for sure, and then look at what other services can be provided within the system. Obstetrics is a great example. Obstetrics has been, I was, my former days, part of the regional perinatal network, so how the hospitals that provide obstetrical services work together. The system was not planned. Tillsonburg, Ingersoll, Kincardine, Wallaceburg all used to provide obstetrics. They no longer provide obstetrics, not because of any financial issue or any planned issue from the hospital. It's a physician issue that there was no longer enough physicians available to provide that service. And we now see it operating at different centers across the geography. You take that to the example of Walkerton and Hanover, both are still providing obstetrical services. Is that a wise use of resources? When you have two hospitals within, I was going to say 15, but someone whispered 10, 15 minutes apart from each other to provide that level of service. You could have a higher volume, higher volume, which means makes it easier for physicians to work within that environment. So we need to look at things from a plan perspective and determine, as the counselor said earlier, where should we put services across our geography? And you can't have everything at every site, but look at where's the most appropriate use of those services. And and we can sit here theoretically and talk about it on paper, but you've got community involvement, you've got physician involvement, all of which are very, these are the things that you'll hear about in the grocery store when you try and make changes to your system. So not easy to make changes. Emergency departments, which has been an issue every summer for the last 20 years, trying to staff those emergency departments. Do we look at different models of using nurse practitioners or having shared services across emergency departments? All great answers, but you need to get community buy-in, because if you don't, the communities are going to rise up and not be pleased.
Just what I always thought, obstetrics would be better in Hanover and Kincardine. Ron?
When LHINs were developing some years ago, one of the things that was emphasized was the consultation with stakeholders, which I thought was a very positive development. Concurrent with the development of the LHINs, there was also a provincial initiative known as the Ontario Partnership on Aging and Developmental Disabilities. And what that initiative was trying to do at the time with the emerging LHINs was to ensure that the access to health care for people with a developmental disability was part of the LHIN agenda. And I know there were a number of meetings, consultations, conversations at a LHIN level and attempts to have them at a provincial level. So I'm wondering, the question is, in terms of access to health care for people with a developmental disability, and by implication other vulnerable populations, what sort of initiatives is the Southwest LHIN and perhaps LHINs across the province engaged in to ensure that access is more reasonable?
It's a great question. I may not be able to provide you the level of detail just because of my lack of knowledge on it, but we fund a number of organizations, Cheshire Services in the City of London, Dale Brain Injury for brain injured patients, and all of those are to provide additional supports to those people living within the community. We're now reaching out across the entire geography of the Southwest LHIN to ensure that those clients are taken care of. And it's actually a model that we're basing, looking at for assisted living. And without going into a lot of detail, assisted living means that you can have a client living by themselves in their own house or their own supportive housing unit, and every so often they get a check-in from a personal support worker. It could be for toileting, it could be for bathing, could be for food preparation. Assisted living is different than a typical program with the CCAC, where you may get one visit a day for 2 hours. With developmental disabilities, that person, they need 15 minutes in the morning to help with getting dressed and breakfast, maybe time at lunch to, if there's an incontinence issue, to take care of those issues. So that's what we recently funded through our high-risk seniors project, is to look at supporting those. This is for high-risk seniors, but also with our clients with developmental disabilities, and changing the way that the service is delivered so that they get less service more frequently within a day, so shorter time periods more frequently within the day. So we've got great organizations, the two that I mentioned, and I'm trying to think, home and community support services in Bruce and Gray, Andy Underwood's organization as well, providing great service to those clients. So I don't know if I answered your question, but definitely on our radar, definitely part of our mandate to ensure that those clients get good service.
Part of it has to do with access to physicians. Some people aren't verbal, or they're not able to put out in 11 seconds, the symptoms. And so the issues never get looked at properly. So I understand about supporting independent living and how that works, but I'm wondering about access to physician care and how that is being managed, ameliorated, to educate physicians, also to educate the support people in terms of how to engage with physicians so that the client gets the service they need.
Yeah, I'd be stretching trying to give you an answer, but I know the organizations that I've mentioned that provide those community supports do assist their clients with their conversations with their primary care physician. To what extent and how that happens, I don't want to. I don't know the answer to give you. And it would be beneficial if council's interested, certainly to have one of the members of those groups, those organizations, come back to council, and they'd be happy to give you more details.
Kim?
Thanks, Larry. A couple of questions in particular. I believe that not that long ago we heard that there wouldn't be any discussion about long-term care facilities built in this area for 15 years. Did we not hear that in the...
I've never heard it directly. I've heard people say that.
Well, there was a report on the radio one morning. They said it, whoever they is. And certainly I appreciate the idea of more home care. I understand that. But you understand the demographics of Bruce County. Bruce County, our population is aging rapidly. And when they go home for that good care, there's nobody home there. So the issue about a substantial length of time before Bruce County, whether it's, and I saw that Jerry had popped out, but he should be tapping you on the shoulder too. On the shoreline, there's a big time demand for a long-term care health facility. It's not like some of the urban areas in our LHIN area. So I would encourage you to consider that, whether it's on the radar or not. We need a little blip on there. The other issue that you talked about that seems to be just wrong, just misinformation, is the relationship between municipal council and the governance of the hospital. And you mentioned, yes, we do hear those conversations in the grocery store about why is this going on, why is that going on. And you said that the relationship has improved so much more in the last 20 years. Totally wrong. That's not the way I would see it at all, because 20 years ago, the mayors of all the communities were on the board of the hospital. There was a direct line of information back to the municipal councils. That doesn't happen anymore. So in many regards, the municipal council, which theoretically, well not theoretically, the public expects us to speak to the hospital with some sense of authority and, this is the way it needs to be. We don't have that at all. So whether you didn't quite get that breakdown in the communication or the dynamics, that tight relationship between the local political body and the hospital is not the tight-knit community with the hospital that it maybe was 20 years ago. We might not, it would be a good thing to get that back, to have a better working relationship, but certainly that connect is drifting apart, not solidifying the way I see it anyways. Anyway, thanks for coming. It's been helpful.
And Mr. Mayor, I should correct. So your last observation is, I certainly understand that, and this council is probably more familiar than any council around the movement of hospital boards to a skill-based board and moving away from municipal representation on this board. So I certainly understand that piece. I was quoted in one local media in Kincardine saying that Mike Barrett said that there'd be no long-term care beds in the next 15 years.
Yeah.
It's wrong. So I would have never said that. We don't make the decision on future allocation of long-term care beds. It's the responsibility of the government of Ontario, not the Southwest LHIN or any of my LHIN colleagues across the province. The government has opened new long-term care beds in the city of London, 2 brand new homes, 168 beds in both cases, a third one's underway. The government's also shifted its investment away from the facilities into investments in community support, so aging at home, which I mentioned just briefly. And I think that, from my perspective, I think investment in community is the right approach. But many people don't agree with me. Many people say that we still need to continue to build the bricks and mortar, places to accommodate the long-term care, accommodate seniors as they require long-term care. So that responsibility for the creation of new long-term care home beds is the responsibility of the government. So I look to each of the political parties to determine who's making those decisions as we come forward to the election. Our focus now is looking at those community investments.
I'm sorry, I need to interject. Doesn't it say what's in, what's out? Long-term care homes. Isn't that what's in your budget?
So the distinction is between capital and operating.
So you're operating.
We don't fund any bricks and mortar. We fund just the operating of all the hospitals. That's why the Kincardine hospital conversation, I've been putting it off to the Ministry of Health. Those capital responsibilities are still rest with the Ministry of Health and Long-Term Care.
Go ahead, Ann.
Thank you for that clarification. That's good. I have concerns about the home care program, or your home first, or whatever. And I know it's difficult to implement change, and there are always problems getting a program that looks great on paper actually working efficiently in real day life. However, the gaps, I feel there's significant gaps. For example, sometimes an elderly patient being cared for at home by a family member suddenly needs an increased level of care. It could be coming from a weekly basis to a daily basis, or more on a daily basis. And one of the problems in our area is there's not always enough staffing in home care, whether it's nurses or PSWs, available on a regular basis. And I know of instances where, well, yes, we'd like to give you, increase it to 2 or 3 hours a day, but we just don't have the staff right now. So what happens is you often, with children or their children not living nearby, you have an elderly person, could be often in their 80s, trying to provide this increased level of care for 23 hours a day. And this is a tremendous burden, and we have long waiting lists, and the burden falling to an elderly person. I still have visions of my elderly relative, attempting to give his wife a needle, and he was 86, and this type of thing. So, do you have any plans to mitigate the burden on the elderly caregivers? Because our waiting list for the long-term care now, it can be 6 months to a year. And I know of cases where the burden is unbelievable on the caregivers. And in this day and age, I just feel it's very, very unfair. Okay, that's a major concern.
Okay. We're using up most of our meeting on this subject, and we're going to have to move on. I just have 2 things myself. One I found very interesting is Transportation Ontario now comes under other, which explains the condition of many of our roads. But it doesn't even have its own place in the line anymore. But the other thing is, could you explain to me, and I had a comment, can you explain to me the difference between a private hospital and a regular hospital? I thought, basically in Ontario, all hospitals operate under that main model, but you've got an anomaly here. So.
Yeah, so I believe there's 8 private hospitals left within the province of Ontario. We have one in the city of Woodstock. It operates similar to a long-term care home, so it's 16 beds. We funded, I think it's about $890,000 that we provide to them, and it's a private operation. It doesn't fall under the Public Hospitals Act. Prior to, it was about 10 years ago, the government at the time went through and actually converted most of the private hospitals to public institutions, or actually closed those private hospitals so that most of the hospitals now are considered to be public facilities. The last big private hospital is Schulich, so where you go for your hernia operations. It's the biggest private hospital that's left within the province of Ontario, but still receives public dollars to do the services that it provides for hernias. I don't anticipate, or I haven't seen anything on the horizon saying that we're going to be getting rid of those private hospitals, but there's only 7 left now, or 7 or 8 left in the province.
So do they still have the same access rules then as the others? They're not
Yeah.
allowed to turn anybody away and all those types of things. They can't turn somebody away for lack of help.
Correct. And the one within the city of Woodstock, as I said, really operates as a long-term care home. So it's for those frail seniors that are requiring acute care, but it doesn't provide any surgery or medicine services.
And I too am one of the people very concerned about long-term care in our communities. To the point though, on long-term care, our region already has long enough waiting lists to have another long-term care home. And this part of the Lakeshore region, I think, is one of the areas of highest demand. I truly believe that we're going to face a crisis within 10 or 15 years. But one of the things that's going on, like I agree with your focus to a point on returning people to their home and that, but then I know for a fact there comes a time when that just doesn't work, and it's not even the most efficient way. You can only have so many hours of PSWs and that, or we're going to have everybody that's in Ontario serving their parents as a PSW when we get there. But the other thing is that long-term care homes are no longer old age homes. They're exactly what they say, long-term care. And many of the people that are not traditional users of those types of homes are now having no other place to go. Places people like what Jackie referred to, those that are mentally ill, are being referred to long-term care homes simply because there's no other alternative to them. They take space for the more traditional client that we would normally serve or think of, and every time they do that, there's somebody else displaced that was a traditional user of them. And the other big one is not just mentally ill, but also people might be 20 years old that can't survive or can't thrive in any other kind of care, whether it be extreme epilepsies or those type of things, and they take up those long-term care beds for 60 or 70 years sometimes. So, I think that both from the LHIN, from our own perspective, we've got to keep the pressure on the ministry to let them know that in our part of the world anyway, we have to have that investment because we're facing migration, not of our creating, and we need the tools to be able to serve those clients which are migrating here, and that's not the kids right now. That's people needing the power users of the healthcare system.
Mr. Mayor, maybe I can, because the questions came up at Bruce County Council as well, and tonight around long-term care. What I can offer is, if council's interested, to have a meeting with some of our staff that are much more knowledgeable about the long-term care business, and maybe some of our CCAC reps to talk to this municipal, whether it's your staff or council or members of Bruce County Council to talk about that conversation. Because it really varies across municipalities. Some of your neighboring municipalities are looking to get out of the business because they're subsidizing their long-term care homes and seeing a significant amount of money, municipal dollars that are going, and they want to get out of it. And I'm hearing something different from Bruce County, so we'd be happy to have a focus meeting if you'd like to do that.
I think that's a great suggestion. We'll have staff get in touch with you and your people.